Hi there, and welcome to the Month of Pain. This is a podcast for two gals and a glass half full. We are Dr. Jess and Dr. Bobby, and we're two physical therapists doing our best to lead healthy lives most of the time. Moderation's key, right? We like to see our glasses as half full. Some days this is harder than others. And we hope to share that perspective with you all by interviewing people more knowledgeable than us. So first, before we get on to our guest, Dr. Bobby, what's in your glass?
Today I have some Clearly Canadian. I don't know. This is like my childhood drink growing up, and I saw it in the store and I was so excited. So how about you, Dr. Jess? What do you have in your glass?
Well, I'm working on staying hydrated. It's warm here in Florida. We've got a test run, just so I don't know if you all can see. There we go. We've got a Two Gals logo. That's not, it'll look better in the future. This is a very test cup, but I've got some coconut water in here because it's Florida heat. So coconut water helps a lot. All right. And so with us today is Dr. Ty Zimmerman. And Dr. Ty, tell us what's in your glass?
What I have in my glass today is actually a little blender bottle, but it is a berry smoothie with a little bit of greens and peanut butter.
There we go. That sounds fantastic. And Dr. Ty, tell us a little bit about yourself.
So I'm a physical therapist. I've been practicing for about 4 or 5 years. I'm board certified in orthopedics and currently undergoing fellowship training in orthopedic physical therapy with Dr. Bobby.
Look at that. So you also care very much about your profession, and helping people is what I take from that.
Absolutely.
Yeah, fellowship isn't a joke. Yeah. So we are in the month of talking about pain during this month. We started off the month getting that nice big picture of pain, and that it's not as simple as sometimes we like to think it is, and that I touch something hot, therefore it's painful. Pain can be so much more than that. And so that's where we started. Now in this episode, what we're going to do is we're going to get a little bit more into some of the nitty gritty with understanding what can we do about pain, but from a physical therapist perspective. In later episodes, we're going to interview other people that aren't physical therapists and their perspectives and what to do. So today, Dr. Ty, when we're talking about pain, we've got that acute pain and then we've got chronic pain. Acute pain meaning that, boom, I'm in pain right now. Ouch, it just happened. And what do I do? Okay. Chronic pain meaning it's something that's been going on for a very long time. So when we go back to acute pain, what are some of the signals that are received via the nerve endings? Like how is that information transmitted to our brain?
So when you're looking at pain, you've got two kind of primary ways that the signal gets to the brain. You have kind of A delta fibers that send pain, and you have C fibers that send pain. The A delta fibers are kind of myelinated. They move quicker, about 20 meters per second. So they're like lightning quick. And that's that really sharp pain. Kind of if you've been stung by a bee, like the initial poke, that really sharp, hard pain, that's more of the A delta pain. When you get those pains, though, you get a release of kind of glutamate, CGRP, substance P, and that helps with the signal transduction and creates kind of the healing factors and all of the inflammation that comes after the fact. After the initial pain, you can start to get C-type fiber pain, which is more that dull, achy stuff, where it's just kind of like everything hurts. And I liken that more to like the little bit of venom after the bee sting. So initially you have that sharp stab, but then you kind of have that dull, achy, like, oh. Why that's important is because you can treat them a little bit differently.
Right. Yeah. So I think that's a big picture of pain, right? Is that all pain is not created equal. So, and how we address pain really needs to be different based on the circumstance that you're in. So if you touch something and it's like, ouch, hot, right? That's actually a good signal because you need to get your hand off of the hot burner, or you stepped on glass and you should probably move your foot off of the glass. So these are protective signals that our brain receives in order to help us survive in our environment. So pain isn't necessarily bad. It is it's a form of survival. However, it's healing from the pain that then, addressing that. So in that acute situation, how would you maybe differ your approach to addressing that kind of pain than the pain that's lasting longer and is more of in that achy sensation? Like, what are different strategies you use?
So kind of like you said, if you step on a piece of glass, that A delta sharp pain, you need to change whatever's causing that stimulus. You need to get that piece of glass out. You need to move away from the hot stove.
Right.
It's more important kind of from what we treat mechanically, changing the mechanoreceptors, moving the sore parts away from what's creating that soreness.
Right. Yeah. Which is, and I think sometimes what we perceive as pain, if it's, and we'll get into this in a minute, if it's chronic in nature, then the brain can start to get a little bit confused and still treat it more like it's that acute pain and that there's some sort of danger. And I think being able to really separate out the different kinds of pain, it's helpful and empowering for people to know what is truly danger, harm, and what is not. And I think the faster that we can have individuals understand that, the faster you can really start to develop your own individualized plan for addressing pain. Right. So, but again, it is acute and then chronic, lasting long duration. So acutely, yeah, we might, like in physical therapy, we might say, yeah, put some ice on that, right? Treat that inflammation that happens, that red hot swollen, right? Maybe sometimes I'll do some compression on that, especially if it's really red hot swollen, with some ice, elevation, muscle pump, all sorts of things to really calm down that really, really acute response, right? Dr. Ty, is there anything else that you typically will recommend in that situation, other than, change the environment, get away from the hot, get away from the glass, whatever the harm is, get away from that. What are other like situational based things that you might recommend for that more acute onset?
So I see in a lot of the really acute stuff, the fresh stuff, there's that swelling reaction that we actually don't want to discourage right away. And this is one of the topics I think is pretty interesting. We probably are icing way more than we need to.
Mhm.
10 minutes after you had rolled your ankle and it's ballooning, absolutely put a little bit of ice on it.
Right.
We don't need to keep icing that for 4 to 5 days after, because we want to encourage a little bit of that protective swelling.
Absolutely.
So kind of educating people that way is important, I think.
Yeah. So is there
I
a
think it's
timeline to go by? Oh, sorry. Go ahead, Dr. Bobby.
I was gonna say, like, for example, I think a common one's like an ankle sprain we can talk about is also like getting treatment quicker. A lot of times, at least in my clinic, we tend to see them 6 weeks afterwards instead of like right away, but trying to get them in quicker so you can provide that education, and not necessarily provide treatment, like kind of let the body do what it's supposed to do, but provide enough education on how they can like improve their situation, improve their pain, and increase the healing speed.
Yeah, and when you look
of
at
that.
just initially 2 to 4 weeks, you start to see a lot of improvement in most tendon and ligament injuries. And bone itself 6 to 8 weeks. So if you're having a little bit of a bone stress injury or something acute like a sprained ankle, it should rapidly get better. So
Right.
if you can get in and get some education quickly on an acute injury that's sharp and painful and you can't walk on, that's more important, because you can prevent some of the chronicity that develops.
Absolutely. Yeah, that's usually like my rule of thumb that I tell patients. I'm like, within 2 weeks, if you're not significantly better after that acute injury, then it is not an over response to ask for help. So that's actually going to push you forward way faster than waiting till 6, 8, 12 weeks later. But like that first 2 weeks, like more or less 50% healing should be done. You should be significantly better within those first 2 weeks if you're going to heal like without any help at all. And it just heals on its own normally. So that's acute pain, right? Inflammation is not bad in the beginning for that first 24 hours in order to be able to sleep, because it's hurting or, it's ballooning and it's just like horribly uncomfortable. Yeah, like treat that inflammation right away. It, typically will help you be able to get some rest. But then inflammation has its own chemical response and it's delivering repair cells, which is helpful to the tissue. So overly restricting that is not necessarily good, but there is a balance between controlling the amount of pain and discomfort so that you can sleep, and allowing enough inflammation to go through. And that's a balance that you typically would work with your physical therapist if it's to that much of an extent. That would be my recommendation.
Yeah, I
So,
like that you mentioned rest, because rest in the first 24 hours, maybe, usually pretty good. But then
mhm,
you want to get into active rest where you're taking a little bit of time off, say running after your ankle sprain, but
yeah,
you can still walk. You can go on a small hike. You can do things that don't irritate, or increase inflammation.
right. And I think what I was meaning more was sleep.
But the more you move,
So yeah, if you can't sleep because you're in so much pain, you're not going to recover. So that's a really big topic that we've been trying to cover in previous months as well,
yep.
is making sure that your body can actually go into that restorative sleep. And when we're dealing with people that are in pain, sometimes that pain signal is getting them back out of that restorative sleep. And this is what we see a lot with, post-surgical patients or people that have these acute disc injuries, all sorts of stuff where they're not sleeping for weeks on end and their bodies are wrecked. So sometimes you really just need to find some way to be able to get the pain controlled to the point where they can sleep. And then that recovery process really starts to happen. The sleep is a definite thing.
Absolutely.
Yeah. All right. So let's talk a little bit about chronic pain. So acute pain, that's very straightforward. I mean, it really is pretty straightforward. It's hot, it hurts, it's sharp, it hurts, it cut my skin, I bled, whatever. Now, chronic pain, this is what I think is the biggest topic that's very misunderstood. And I think this is what deserves a little bit more of an understanding. You might disagree. I just know from my patient population, chronic pain can be they think of it more as this mechanical cause and effect, when really there's so many other contributing factors for what the brain is perceiving as a painful area. I don't know, Dr. Ty, if you feel the same, if you've seen that with your patients.
Yeah, as soon as it becomes chronic, it becomes so much more complicated. And if
Yeah.
you know a little bit more about the neurophysiology, what's happening, it makes a lot of sense, because there's so many different areas of the brain that start to smudge together, that start to bring in emotional, experiences, connections into that pain response.
Right. Yeah, and this is what we covered in the previous topic, is the stress response, the emotional response, plus that mechanical response. So all of these are working together for what your brain is perceiving as pain. And so if you haven't slept well, or you have that relationship in your life that's really stressful, you were just in a big argument, work is really getting you like overworked and overwhelmed, or whatever it might be, that amount of pain that you're feeling is going to be higher. It just is. So it has nothing to do with, those stitches not healing well, or the bone not healing like it's supposed to. Sometimes there is all these other contributing factors. So being able to really take some time and separate that out is helpful. But from a mechanical perspective, right? So we've got that pain signal that comes in. You're talking about those fibers that come in. Can you talk a little bit more about what happens when that signal comes in? So I've got a little receptor in my finger, right? And that signal comes onto a nerve ending, and that nerve ending travels through my arm to my spine, and it goes up to my brain, right? So what happens when that signal has been going on for a long time, like more than a couple of weeks? Same signal,
So,
same signal.
right. The more that signal starts to play on, the more it starts to activate the other parts of the brain other than the somatosensory cortex. You start to see an increase in like the anterior cingulate cortex, the emotional experience, and it actually sensitizes those parts of the brain so that they react to a lesser level of insult. So even though that little pinprick in your finger keeps getting sore, less of a pinprick, and then all of a sudden a light touch will start to sensitize and engage that same area of the brain. It's actually powerful how that happens.
Right. So it's quite interesting, because the and that's kind of what we kind of talked about too, is thresholds. And so typically we have this threshold that might be up high, right? And I could stub my toe pretty hard, and it's gonna hurt, but like it'll stop in a minute. I'm just kind of ticked off for a minute. But when my threshold is lower, we'll say down here, if it's not, I might stub my toe, but I might like barely nick it. And then all of a sudden my brain is just like, whoa, yeah, that was really, really hurt. And it stays hurting. And now it's my whole foot that hurts, not just my toe. And then it starts to become this like really convoluted signal. And then it's hard to understand why this is happening. But I think what you were explaining with how the brain itself becomes overly sensitized, which is interesting. It gets overly sensitized to pain. Now I can start to see how people stay in pain for long duration and how things maybe show up on imaging, right? Or maybe they don't show up on imaging. Maybe I'm in all of this pain and I have every scan in the world and it shows nothing. That's infuriating. I mean, absolutely infuriating. How would that not be infuriating? There has to be a reason for this, but it could be that the brain has just become overly sensitized. So Dr. Tai, in these situations, what are different strategies that you use with patients when nothing shows up on imaging, but they clearly are experiencing pain?
I think just what you're talking about, giving them a little bit of the education. I think some of the pain neuroscience education stuff that we do for patients is helpful. It just can't be a standalone treatment. So helping them to understand that there are these processes in the brain where you have this insult and then the chronicity develops, your brain starts changing. People can understand that usually pretty well because they have the experience on the other end of things. You've heard the stories of like a mom that has an injury but then can lift a car because her infant's getting hurt.
Right.
You guys have heard of Carrie Struggs, right?
Tell me more.
Yeah.
I'm bad with memory names.
And gymnast, 96 gymnast,
Okay.
Yeah.
vaulted on a broken ankle to win the gold for US.
Yeah. So if pain was just a signal that stops your brain from doing something, she wouldn't have been able to do that. But like
Right.
you're talking about the stub toe example, all of a sudden there's this tissue damage. It's not even that bad. It's a potential threat that your brain on a bad day, when I've poked my wife a few too many times and she's not having a good day already, didn't get her cup of coffee in the morning, she gets a little more angry when that happens.
Don't mess with her. She has not. I'm saying I am a wife of somebody. Don't do it.
I like to
Exactly.
also explain to my patients on how those pain, the signals after a while continue to be sent. Their brain is still receiving, even though there's no tissue harm, their brain is still receiving the signals as if tissue harm is happening, to kind of help them understand like why they're still feeling that same pain that they felt the day they injured it 2 months, 3 months, 4 months later. But that, just the brain is reading that as damage, 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 even though it's not necessarily further damage that's occurring.
Mhm. Yeah.
And then it's finding a way to decrease those signals, finding a way to change those signals. And I think that's where a huge aspect of therapy can come in, to try to like figure out how can we change what the spinal cord, what the brain is receiving.
Yeah. And I think that's with the dry needling training that I did. There was a lot of research with dry needling and being able to treat, for example, trigger points and help with that constant bombardment that can happen by a trigger point being present inside of the muscle, which is just a palpable band, right? So if I've got my forearm here and I'm like rolling, I'm flicking over a top band in there, and that band, and maybe it even refers pain further down into my forearm. If I treat that part of the muscle that's just holding like that all the time, that's one strategy to help to decrease that bombardment, right? So there's different things that could be contributing to that bombardment that we might not realize are, and they could receive help. Dr. Tai, what are other things that you've noticed that develop other than trigger points that can be contributing to that constant bombardment, and how we can get it down and quiet that back down again?
I think nerves are a big, big player. If there's tension at all along the nerve root, I tell most of my patients, hey, it's like a garden hose. If you've got a little kink in your shoulder and your neck, you're not going to get any water down at your wrist. And
Right.
maybe it's a carpal tunnel or maybe it's a cervical radiculopathy, but you can treat the neck to have an effect downstream at the nerves.
Right.
And similar to your trigger point example, if we're talking about the elbow, like the radial head, if you're not supinating completely while you're trying to carry something, you're going to lose a little bit of strength. The muscles are going to have to work a little harder. They're going to have to pull that stiff joint. And now they're going to create more resting tension, resting EMG.
Right. Yeah.
So
So yeah, no, I think I love this topic because it's so interesting, all of the different things that can contribute. And you've got to think up the chain, you've got to think down the chain, you've got to think nerve, soft tissue, joint, ligament. Everything really should be as normalized as possible in order to decrease that pain bombardment. It's typically not just we put our hand on the point that's painful, treat that, and then it all just calms down. There's usually so many contributing factors that you just need to have someone take a step back and really understand, why is this happening? Treating the symptom, I mean, that's easy. You point to it, someone treats that, sure, but that's not necessarily going to stop that chronic bombardment. And I think that's something that sometimes when people have tried different things in the past, they're more treating the symptom of the pain and not necessarily the cause of pain. And that's where I think us as physical therapists, that's something that we're trained to do. And hopefully there's other practitioners out there that are also trained to look for the cause for whatever might be going on. Now, that brings me back to imaging. So we're going to kind of bring that back. So we talked about the person that has imaging and it's negative, and that's so frustrating because you have symptoms and the imaging is negative. Now, let's go to the person that has imaging, but the imaging is positive. Okay, so we've got, let's go with spine. Okay, so we've got degenerative disc disease, a really broad one. I guarantee you, if you imaged my spine, I'd have degenerative disc disease. I've had 2 pregnancies. It just, I'm not in my 20s anymore. So anyway, so Dr. Ty, what is your perspective on imaging and using that to help guide some of the decision making that you do inside the clinic?
Well, there's kind of 2 big things. Absolutely. When you have an issue that needs to be imaged, it needs to be imaged. You're ruling out something. I have a lot of primaries, a lot of medical practitioners that just order imaging because there's pain. And that doesn't always help. And it starts to have people develop this kind of fear avoidant lifestyle where they say, I have degenerative disc disease. It hurts every day. It's never going to get better.
Right.
But that's just a normal part of aging.
Right.
There's a really cool study. Brzezinski in 2014 took a whole bunch of asymptomatic spines, people that were just off the street, and they took imaging of it. And anywhere from 20 to 80 years old, and they just found out how many findings these people that had no pain walking down the street, what was wrong with them. And when you start looking through the table, I actually show it to most of my patients that tell me, oh no, I have a disc bulge, I'll never get better.
Right.
After 30, if you don't have degenerative disc disease, you're actually abnormal.
Right.
Like you're in trouble if you're clean at that point. 40% over the year 50, you should have disc bulges, protrusions. It's just part of aging. It's not always, and that brings us back to kind of the whole pain, A delta C fibers. It doesn't always have to be in tissue injury and insult. It's something pinching on a nerve, on a disc that causes the inflammation or the pain. There's a lot of other reasons you could have pain.
Absolutely.
I think one of my favorite quotes, and I heard Tamara actually say it when she was teaching a class first, is that imaging is a static picture of a moving body. And that when you have an image, you're only seeing a specific part of your body at a specific point of movement, and you don't live in that movement the whole time. You're constantly moving through. If we imaging that we watch everything as you move, that would be pretty cool. And it'd give us a lot more information at that point because you can see what's happening as you move. But I think a static image is really good sometimes for those red flags, those emergency situations that need to be ruled out.
Yeah, the red flags are key. Are we dealing with a fracture? Are we dealing with a full-blown herniation into the central cord? Are we, all of these things that are actually really, really bad for sure. Imaging, rule it out. But I with the degenerative disc disease, I kind of point to my hair. I'm like, you see those grays in there? Because I don't cover them up yet. I don't know if I will. I'm still on the edge with that. Probably not. I'm gonna let them go. But anyway, so I've got grays. Okay, that happens. That's my aging process. I've got some wrinkles starting here. Okay, just a few. I don't say more than a few. Then I also have the start, most likely, of degenerative disc disease. That's not necessarily a bad thing. It's just a contributing factor. Would that maybe decrease my threshold a little bit compared to what it was? Sure, right? So my threshold might not be up here anymore. It might be here, but that doesn't mean that every single thing that I'm doing that's hurting my back is just because of this one diagnosis. So, and I think that's where kind of taking that step back and really understanding imaging from a little bit of a different perspective and not letting it label you is something that I really work on inside the clinic with my own patients. Because those labels that you put on, it's like, it's my bad shoulder, it's my bad back. That's yours. Don't call it a name. Be nice. Jeez, it's never gonna get better if you speak mean words like that. So, so Dr. Ty, what are some of the most common findings? I use degenerative disc disease because that's one I just hear all the time. But what are some other common findings that can be kind of normative?
Facet degeneration, that's a really scary sounding term, which is
Ugh.
essentially degenerative disc disease, but just on the outside of the spine, right?
Yep.
All the disc things, signal height loss sounds terrible.
Mhm.
It's just a little bit of loss of water content. We don't move as efficiently when we get older and we lose that kind of bounciness.
Mhm.
And that's just what you're seeing. Disc protrusions, bulges, herniations, annular fissures, all those things that can happen at the disc show up, but they're not bad. Even things like a spondylolisthesis, they show up, they're not completely abnormal. The interesting one I've been seeing a lot more of are compression fractures and insufficiency fractures, where I
Mhm.
have someone coming in that's maybe got a little osteoporosis, maybe not as active at 70, 80 years old, and they're having back pain. So they get an image and they're like, oh my God, my low back is killing me. I have a fracture at T12. Like, no, your image says that was from a while ago. It's a healed T12 fracture and you have low back pain. I understand, but that's different.
Right, T12 is in your mid back. So yeah, so if it's in the low back, then why would that mid back fracture cause low back pain? No, I think there might be something else going on. Yeah.
Well, that's, and Ty, as you said, with spondies, I had a gymnast who had bilateral fracture, slippage, not great in a gymnast. And the first physician she went to see, he told her career was over. And this kid is 13, 14, and her whole life has been to do college gymnastics. And to walk into a room and have a doctor very coldly say, "We are done." And so they call me obviously upset. And I'm like, no, no, no. I'm like, no. And ultimately they found another physician that was great with kids and helped her. And obviously had to take time off, had to do a lot of therapy, had to do a lot of strengthening, but she is back in the gym, pain-free. Yes, they don't know if the fracture will ever heal. They don't know like if that slippage will ever, it's probably there forever, but she has no pain. She's doing great. She's learned how to manage it. And I think a lot of times those words just scare us. And there's sometimes practitioners and not just doctors that say detrimental wording to us instead of like giving us chance to get back to what we love and what we want to do.
Right. Yeah, I think that's the number one thing that I try and do as a takeaway with imaging. Imaging is really important, especially when we're looking for red flags, things that are unstable, things that could create long-term damage. Obviously, those are situations that might require surgery, might require something a little bit more intense. And for sure, that's all on the table. That's all a possibility. The biggest thing is making sure that if you have positive imaging, take it a step further and just really make sure, is this situation an unstable situation, or is this situation a situation that could be managed? Okay, so like managing our bodies is not a bad thing. Maintaining muscle length, strength, mobility is just good. We maintain our cars. We bring in for oil changes and we put it on the tires every so many miles, and the band things that go around the serpentine belt, and the spark plugs. So we maintain that vehicle to make sure that it operates at this level that we want it to operate. But when it comes to our bodies, it's like it's either broken or not. Well, why does it have to be broken or not? Why can't it just be we're maintaining this body that's aging in time? I mean, that's just a concept that we could go on using imaging to think about it that way. Well, what are all of the things that I need to be aware of to make sure that maybe I do keep a stronger core. Maybe I do really keep my hips moving. Maybe I really do work on maintaining my mobility, because I know I've got some stuff going on in that low back, but it doesn't stop me from doing anything I want to do. I make sure it doesn't. And I work with somebody that understands that. So that's just my perspective. And I think Dr. Bobby is very similar, and Ty has such a great understanding of the research and everything that goes into pain, that it's like helpful to hear, even from that just more research perspective, that this is not just like us blowing smoke. It is evidence-based. So that being said, Dr. Ty, I want to say thank you so much for coming on. We really appreciate you being part of this conversation. Raising awareness of what is pain is something that we are passionate about. We want to make sure that we share that with our viewers, and that pain doesn't have to be scary. It can be something that just takes a little bit more time to understand, and just kind of take a step back from that a little bit. It's a really, really broad, complex topic. Make sure listeners follow us on our social media platforms. We're on Instagram, we're on Facebook. Eventually we might be on TikTok. Not yet. We are working on it. But please do subscribe so that you get updated information as we release it. We do release once a week. So we appreciate you all, and thank you for joining, Dr. Ty.
Thank you.